Welcome to Practical Guide to Insulin Therapy in Type 2 Diabetes. This module has been prepared by family medicine specialists in Pejabat Kesihatan Daerah Hulu Langat to increase the understanding among medical officers in the state of Selangor. Happy learning! These are the subtopics of the module, which will cover from basic understanding of insulin, application of knowledge including insulin initiation, optimization and intensification, not to forget the monitoring and management in special situations like during period of illness and travel. It will also highlight issues in dealing with insulin and some practical tips. Based on National Health and Morbidity Survey and HMS Report 2019, overall prevalence of diabetes among adults is 18.3%, which has increased compared to previous years. Furthermore, data from National Diabetic Registry 2013 to 2019 reported that only 32% patients achieve good HbA1c control. We need to gear up the effort and be more vigilant as nearly 70% of type 2 diabetes mellitus seeking treatment in our clinic kesihatan compared to private facilities. This opportunity to treat NCD earlier will further reduce the financial burden on managing its complication. Also from NHMS data reported that only quarter were given insulin compared to oral anti-diabetic agent and dietary advice. Wondering what contributes to the low usage of insulin? Let's see some of the answer in subsequent slides. But before that, let's first learn about the rationale for starting insulin. First rationale, insulin resistance and impaired insulin secretion form the two key factors behind type 2 diabetes mellitus. These can even occur among those with prediabetes. At diagnosis, pancreatic beta cell function was found to be approximately 50% of its normal with a decline of 5% each year. By the 6th year, pancreatic function may be less than 25% of its normal. Next, type 2 diabetes is a progressive disease characterized by worsening glycemia. There are many reasons why beta cells continue to decline. One of the important reasons is glucose toxicity. The progressive decline in beta cell function ultimately renders oral agent ineffective, and the majority of patients with type 2 diabetes will eventually require exogenous insulin treatment. Third reason, besides restoring circulating hormone levels, insulin treatment has other beneficial effects. Insulin is widely accepted as a good option to achieve glycemic control. It also had good safety profile and can be usually combined with other oral antidiabetic and injectable agents. Compared to other oral hypoglycemic agents, the fourth rationale showed that reduction in HbA1c is maximum with insulin therapy. This was described in detail through systematic review by Esposito et al. In 2012, whereby all insulin types significantly offer more than 1% of HbA1c reduction. Hence, early initiation of insulin can help to reduce further deterioration of beta cell function and prevent associated complication. Following that, study by Stratton et al. In 2000 highlighted that the risk of diabetic complications among type 2 diabetes was strongly associated with previous hyperglycemia. In this study, each 1% reduction in HbA1c was associated with reduction in risk of associated complication as described in this table. Hence, the role of insulin and its pathogenesis should be discussed during consultation, especially during initial diagnosis. Introduce them the eventual need for insulin so that it is not used or perceived as a punishment for their poor sugar control. As we are all aware, insulin is to be added for glycemic control after optimal dose of oral antidiabetic agents. However, Insulin should also be considered in short-term usage as in acute illness, surgery, or pregnancy. It can even be used as initial treatment for type 2 diabetes when the HbA1c at diagnosis is high, more than 10%, or fasting blood glucose more than 13 millimole per liter. Now, let's discuss in depth on several barriers to insulin therapy as I've promised earlier. Barriers to insulin therapy can be divided into patient, healthcare professional, and system barrier. Common patient barrier are fear and misconception about insulin therapy. Patient may seek for alternative treatment due to this perception. The barrier is made worse with lack of knowledge plus negative influence from family members. Among healthcare professionals, the barriers include different level of understanding and knowledge, lack of training, which contributed to undesirable attitude, motivation, confidence on initiating insulin therapy. Due to this, patient may receive conflicting advice on such therapy. Top-down, lack of good healthcare system is one of the biggest barriers. These include lack continuity of care, manpower, resources, language barrier, as well as uncoordinated changes in the system. International Diabetic Management Practice Study, IDMPS 2006, have shown some of the barriers towards low insulin usage. Apart from poor patient's acceptance, non-adherence, fear of hypoglycemia, and inappropriate timing of injections, treatment or physician inertia is one of the issues that has been identified. What is inertia? It's a tendency by physician to do nothing or remain unchanged from initiating or intensifying therapy in a patient who has not achieved therapeutic goal. There you go. Anyone has similar experience? Do not worry. This attitude can be improved. Hence, this module will be relevant to shed some light and recap the knowledge in hope to reduce this barrier within us and enhance confidence in managing insulin in primary care, inshallah. These two subsequent slides will be on the tips and suggestion on how to encounter or tackle our clients in regards to possible barriers of various issues with insulin. For example, some clients do believe the myth that insulin may cause complication like kidney problem, even death. Suggested solution will be first to acknowledge their fear and provide correct information to counteract their disbelief. Please take your time, pause in between to revise at your own pace. Now, let's discuss on insulin types and regimens. The insulin currently used in Malaysia is recombinant human insulin, either directly derived from the native human insulin or structurally modified, which is insulin analogue. These are further divided into Prandial, Basal, and Premixed Insulin according to their pharmacokinetic profiles. Prandial insulin is administered pre-meal because of its short or rapid onset of action for controlling the postprandial glucose excursion, while basal insulin is administered once or twice daily. The intermediate or long-acting pharmacokinetic profile cover the basal insulin requirement between meals and overnight. On the other hand, premixed insulin is biphasic insulin that incorporates the combination of short or rapid-acting insulin with its intermediate-acting counterparts into a single preparation to cover both postprandial glucose excursion as well as basal insulin needs simultaneously. Further details on type of insulin preparation is highlighted in these tables. It describes the onset of action, peak, and duration of action, as well as the timing of insulin administration. This table also explains about short-acting or prandial human and analog insulin. This table describes about premixed insulin preparation, while this table describes about basal insulin preparation. As clinicians, we also need to be familiar on differences between conventional and analog insulin. Please take your time to differentiate the characteristic between those two. In principle, insulin analog is designed to improve pharmacokinetic profile that mimics physiological insulin. Individuals with the following situation, such as intermeal and nocturnal hypoglycemia, require dosing flexibility due to work-related and lifestyle restrictions, and unwilling to go for NPH twice daily, should be considered for insulin analog therapy. An ideal insulin regimen should mimic the physiological insulin response to meal and endogenous hepatic glucose production. The main advantage of insulin is that it lowers glucose in a dose-dependent manner. But its disadvantages are hypoglycemia and weight gain. A basal bolus therapy using the combination of long-acting basal and rapid-acting analog mimics closest to endogenous insulin action. However, it requires multiple numbers of injections. At the end of the day, the choice of insulin regimen should be individualized based on the patient's glycemic profile, dietary patterns, and lifestyle. These are the various insulin regimes options to offer to your clients. The choice of insulin should be individualized. To achieve successful insulin therapy, it requires a three-stage process. Initiation, which is starting insulin. It requires selection of appropriate insulin regimen, insulin type, and starting dose to address the individual's mean glycemic abnormality. Second, optimization, which is dose titration or adjustments. It requires gradual, safe, and prompt titration of insulin dose according to self-blood glucose monitoring towards an optimal dose to ensure maximum benefit from prescribed treatment. The insulin dose should be adjusted at least weekly to get the monitored reading to targets. Optimization of the insulin dose should be an interactive process between the healthcare provider and the patient. This can be done at the Diabetic Resource Center or via telephone calls. It should be done within the first few months of starting insulin. Last, intensification, which is a modification of an insulin regimen to achieve better glycemic control. It requires switching to more intensive insulin regimens for better glycemic care. Now, let's learn on how to initiate and optimize insulin. Initiation of insulin, it will be based on patient's preference, blood sugar profile, and lifestyle. The table shows the preferred insulin regime based on patient's blood sugar profile. For instance, for patients with high pre-breakfast alone, basal insulin is the preferred option. Few examples of basal insulins are Insulatard, Insugen N, Glargine, and Basalog. To initiate, at dose of 10 units at bedtime or 0.2 units per kilogram. However, patients with leaner build, elderly, and mildly elevated fasting blood glucose, we can initiate at 0.1 unit per kilogram. Optimization should be done by adjustment of insulin dose following 3 consecutive blood glucose value to achieve our desired fasting glucose as stated in this table. However, please be aware on nocturnal hypoglycemia episode that may limit optimization. In this case, we may need to consider switching to basal insulin analog. With regards to premixed insulin, it may be initiated once daily, usually at pre-dinner, or twice daily at pre-dinner and pre-breakfast. Examples of premixed insulins are Mixtard, Insugen Combo, and Novomix. We can start with 10 units per dose or 0.2 units per kilogram at pre-breakfast and pre-dinner. During optimization, consecutive blood glucose should be monitored. If pre-breakfast blood glucose is suboptimal, pre-dinner premixed insulin should be adjusted. Similarly to suboptimal pre-dinner blood glucose, warrant pre-breakfast premixed insulin adjustments. If intermittent hypoglycemia limits us to achieve optimal target, may consider to use premixed analog instead. Example of Prandial insulins are the one and only Actrapid, Insugen R, and Insulin Rapid analog, which is NovoRapid. We can initiate at 6 units per dose or 0.1 unit per kilogram for each meal. Its optimization depends on patient's meal type and amount of carbohydrates intake. Blood glucose value should be used as guide to optimize insulin accordingly, as listed in the slide. Carbohydrate counting, insulin to carbohydrate ratio, and correctional dose adjustment ideally should be taught to patients on prandial insulin. Now, how about basal bolus insulin? The aim of optimization in basal bolus is to achieve optimal pre-bed and pre-meal blood glucose. So, do fixed fasting first, yeah? Excellent. Please be aware that there is no limitation to insulin dose. However, we need to find the secondary problems in patients that insulin requirement exceed more than 1.5 units per kilogram per day. Let's talk about insulin optimization and intensification. Type 2 diabetes is a progressive disease. With increasing duration of disease, there is increasing fasting and postprandial hyperglycemia as a result of progressive pancreatic beta cell failure. Hence, insulin therapy needs to be a dynamic process. To address progressive insulin deficiency, the use of a single insulin regimen may often not ensure durable glycemic control over time despite optimization of insulin doses. Many patients are left on an inadequate insulin regimen for too long, resulting in suboptimal glycemic control. Intensification enables modification of an insulin regimen either with additional injections or switching to different insulin types towards achieving better glycemic control. When is the right time to intensify basal insulin? From the study stated that approximately 1 year with dose of more than 0.5 unit per kilogram per day but failed to achieve good HbA1c control. Basal insulin regimens can be intensified by any of the following ways. First, switching to premixed regimen, usually given once, twice, or even TDS. Second, addition of 3 pre-meal short-acting rapid insulin called as basal bolus regimens. Third, sequential additions of pre-meal rapid, which is called basal plus regimens. These are several key considerations that need to be evaluated in making decision to intensify basal insulin to premix or basal bolus regimen. These include number of injections, frequency of self-blood glucose monitoring, and finally, the ability for our patient to inject themselves or need assistance. For those patients on both oral antidiabetic agent and basal insulin, but still unable to achieve targeted HbA1c despite optimal fasting blood glucose, these may be due to postprandial hyperglycemia. Therefore, adding bolus prandial insulin prior to each meal will help to improve overall glycemic control. This regimen is called Basal Plus. If repeated HbA1c at 3 months fail to achieve desirable target, do add prandial insulin at second largest meal and do consider third prandial insulin at final meal of the day. This regimen called basal bolus. Following this, remember to off sulfonylureas, but metformin should still be continued. There is another way of intensifying basal insulin, which is switching to premixed regimen. This option is usually appropriate for patients who prefer a simpler regimen and unable to tolerate 3 to 4 injections per day with a rigid lifestyle especially. Sulfonylurea should be stopped, but metformin should be continued. Dose for dose transfer can be used where the total daily dose of basal insulin is used to determine premixed total daily dose. Premix is then administered in 2 divided doses, usually equal in amount, split dose of 50 to 50 at pre-breakfast and pre-dinner. Premixed analog may be considered in patients experiencing hypoglycemia with conventional premixed insulin, and in those who desire greater flexibility, as administration of premixed analog does not require specific timing prior to meals and may be injected just prior to, during, or immediately after a meal. For those patients on an optimum single premixed insulin regimen and yet still poor HbA1c targets, an option for intensification would be to initiate additional pre-meal dose of premixed insulin. In those receiving BD premixed analog insulin like Novomix, additional third doses may be initiated at midday meal, either sequentially or simultaneously. It is not usual to administer conventional premixed insulin more than twice daily in view of concern for in-between meal hypoglycemia. Please refer to the highlighted table for TDS premixed analog insulin dose adjustment. Metformin to be continued, yeah? For those patients already on a premix daily at pre-dinner, but still not achieve HbA1c target and high fasting plasma glucose pre-lunch and pre-dinner, intensification would be to initiate additional rapid short-acting insulin at morning and midday. Whereas for those patients already on premixed twice daily regimen, an option for intensification would be to add Prandial short-acting insulin of 6 unit or 0.1 unit per kilogram per day at lunchtime. Another option for intensification would be by switching to basal bolus regimen. This option is appropriate for patients who require greater flexibility in dose adjustment as it potentially allows pre-meal rapid insulin to be adjusted individually according to blood glucose level and carbohydrate contents. Starting dose of 0.5 units per kilogram per day or total dose transfer from total daily dose of previous regimens divided into 50-50 basal and prandial insulin. The 50% of prandial dose is further divided into 3 main meals. I hope I don't put you all to sleep as yet, as we still have 100 slides to go. No, I'm just kidding. Now, let's discuss on how to determine the control target and monitoring. But before that, I want to instill this thought process with all of you. During follow-up, these are the items that we need to assess with our patients. Number 1 is to assess their compliance. Second, presence of hypoglycemia episode. Then only considering titration confidently and correctly. Finally, ask yourself whether the desired targets has been achieved or not. So, let's learn on this. Targets and monitoring. As a general rule, the target is to achieve HbA1c of less than 6.5%, as this may reduce the risk of micro and macrovascular complications. Monitoring methods can be done via fasting plasma glucose, HbA1c, self-monitoring blood glucose, and continuous glucose monitoring. Consider less stringent targets in the following condition, such as elderly patient, presence of other comorbids like heart failure, chronic kidney disease, or patient that prone for hypoglycemia. This is the summary of targets for relevant glycemic measures. For fasting or pre-prandial, the target is between 4.4 to 7 millimole per liter. For postprandial, it's between 4.4 to 8.5 millimole per liter. On the other hand, HbA1c target will be individualized depending on patient's background and profile. Please refer to Table 3.6 in Clinical Practice Guideline Type 2 Diabetes Mellitus Edition 2020 for target of each group. This will be the recommended timing of SMBG in different insulin regimen. Once preprandial glucose levels are achieved, postprandial glucose testing is recommended for fine adjustments of insulin dosage. This will also enhance patients' engagement in monitoring their own health. Following insulin titration, any requirement of high-dose insulin of more than 1.5 unit per kilogram per day should prompt a search for an underlying cause or secondary problem. This may include issues of non-compliance, incorrect dosing or timing of injection, hypertrophy of injection sites, intermittent hypoglycemia with rebound hyperglycemia, expired insulin or expired strips, and possibility of occult infections. Upon initiating insulin therapy, don't forget to educate the patients and family on issues related to it. Those with concomitant use of insulin secretagogue, advanced age may experience hypoglycemia. Weight gain may occur to those using sulfonylurea. Injection site problems such as lipohypertrophy and lipoatrophy should be also anticipated. And finally, assess on insulin allergy and hypersensitivity, even the occurrence are rare. Now, we'll be discussing on insulin management in special occasion, which include management during sick days, traveling and exercising. However, management during prolonged fasting in Ramadan and diabetic in pregnancy will be discussed in another module by my other colleagues. There may be times when the patient cannot eat solid food or follow their regular meal plan because of concurrent illnesses, undergoing dental or surgery. Maintaining glycemic control during periods of short-term illness is important to prevent complication. Potential problems during sick days are as following. Hyperglycemia happens even if the patient's appetite is poor because of continuing release of glucose from the liver and insulin resistance secondary to infection. This may also precipitate ketoacidosis. Hypoglycemia, on the other hand, example, in acute gastroenteritis, often cause low blood sugar level because the patient's appetite is often decreased and the food and drink that is taken is not being well absorbed and leads to potential dehydration. During acute intercurrent illness, insulin-treated patients will need to pay special attention to monitoring and self-care practices. Table 9.1 indicates principles in managing insulin-treated patients with acute intercurrent illness. More importantly, to look for red flags that indicate need for referral and admission, such as repeated vomiting, labored breathing, abdominal pain, elevated sugar level despite insulin, or confusion might indicate possible ketoacidosis. Okay, now, during long-distance travel, patients requiring insulin therapy will need to plan travel and holiday in advance and seek advice whenever necessary. Ideally, glycemia, blood pressure, and lipids should be under control. It is important to find out the types, formulation, and strength of insulin which are available in the area of destination. Following table indicates the appropriate advice and instruction to be given to insulin-treated patient. Some of important keynotes are to bring extra medication, devices, cool bags, and even to advise splitting the amount into two different bags just in case it gets spoiled or lost. Not to forget to put some sugary snacks in hand luggage if any hypoglycemia during traveling. With long-haul flights, they may need to adjust insulin doses due to changes in mealtime, activity, and time zone. Do advise your patient to frequently monitor blood sugar, meal selection, and remind on potential food-waterborne infection and food wear. Now, let's turn our attention to exercise. Just like persons without diabetes, many individuals with diabetes engage in exercise of high intensity or long duration, enjoy unplanned exercise, or even participate in adventurous types of exercise. Even American Diabetic Association recommends aerobic and resistance exercise in individuals with type 2 diabetes, including those receiving insulin therapy. However, prior to exercise, insulin-treated patients should undergo complete evaluation, including food, respiratory, cardiovascular, and eye screening. Insulin-treated patients may experience unstable blood glucose level in relation to exercise with an increased risk of both hypoglycemia and hyperglycemia. Risk of hypoglycemia is due to reduced insulin resistance and reduced insulin requirement, while risk of hyperglycemia is a result of stress hormone release. Advice is given to patients with regards to monitoring lifestyle and insulin dose adjustment prior to, during, and after exercise as stated in Table 9.3b. Let us now discuss some practical issues on the use of insulin. Although manufacturers recommend storing insulin in the refrigerator, injecting cold insulin can be painful. To avoid this, insulin vial that is open should be kept at room temperature. Insulin kept at room temperature will last approximately 1 month. All unopened vials should be stored in the refrigerator between 2 to 8 degrees Celsius and can be used before the expiry date. Other relevant tips for storing insulin can be referred in the bubble format as above. The site of insulin injection greatly influences the absorption level and effectiveness of the insulin. Insulin injection site rotation is as important as the amount of insulin taken. Here are some general tips with regards to injection sites. Number 1, give the injection in the abdomen, thigh, and back of the upper arm. 2, choose a slightly new location for each injection. 3, always inject insulin into fatty tissue instead of muscle. 4, give your injection at the same time on each day. Finally, keep accurate record of site rotation. Initiating insulin therapy will only be effective and complete with proper education regarding injection technique. However, even with proper education by a certified diabetic educator, problem may still exist. Injection problems can occur with the use of a vial, syringe, or a pen device. These are 5 common insulin injection problems: painful injection, bleeding at the site of injection, insulin dripping after injection, insulin leaking from injection site, or injection device is clogged. Here are some tips you can refer to on addressing the problems. Take your time to read, and I hope you could share these tips with your patients. We have finally come to the end of this module. It is hoped that all of you will be able to benefit and confidently apply the knowledge. Here are some take to the clinic message. Identify candidates for insulin therapy initiation. Select insulin replacement based on patient's glycemic profile, dietary patterns, and lifestyle. Then choose regimen appropriately, either basal, Prandial, Premixed or Basal bolus. Identify possible barriers and treatment inertia should be avoided among physicians. Do assess compliance and risk of hypoglycemia before titration of insulin to achieve desired target control. And finally, educate. Educate your patient regarding type 2 diabetic pathophysiology and beta cell function declination even as early as diagnosis so that it will not perceive as a punishment when their sugar control is poor and haywire. These are the references that has been used in producing this module. Thank you and have a nice day. Bye.